It's a good reminder of why I went into research, because there were too many times we cried. So the new section, Dan said it's supposed to be uplifting. So let me say we're transitioning to a different kind of research. We're transitioning to a session on patient-centered research. And you might say, well, what's patient-centered research and what's patient-focused research? Patient-centered research is when the patients are identifying what needs to change. When the patient's voice is being heard. When we talk about what are the unmet needs, in this case, the ALK community. So we're working on a new website in the new medical section. We're going to end at least 5 different research projects that you can get involved in. It doesn't require you to travel. It doesn't require you to take a drug, but it's where you can make a difference for people in this room and generations to come. So I just learned about this yesterday, and I'm bringing it to your attention now. Sorry, Tom, I'm stealing a little bit of your time. But at Mass General, Dana Farber, and Jessica is one of the leaders of it, there's a program called the Young Lung Cancer Study. The idea being that if you're under 45 and you get lung cancer, you're more likely perhaps to have a genetic vulnerability. And so this study is anybody that's 45 years old or younger, and they're going to be looking in the genome across people with all kinds of oncogenic cancers to see if we can identify, is there something that predisposes people? So now they can be screened and followed, and they aren't stage 4 by the time it's identified. Thanks to Brittany, these sheets are printed, they're outside on the table. Please take one and contact them. And what we want to make sure, you've heard me say this already today, that there are enough ALK patients in this study that we can understand it. It can't be, 90% EGFR. It's got to be 30%, and Jessica can tell the percent, but it needs to have a large number. So please consider that. Tom Stinchcombe is going to come up. Tom and I were asked by Pfizer to be on a steering committee for a patient-centered project they're doing. And so Tom's going to show you how it's designed, what we're learning so far, and then invite you to be a part of that. We have several more of these coming from other research programs, so I'm hoping that this will be something that you'll find of interest, and it will help us get the information to the pharmaceutical and biotechnology companies on exactly what you want in a therapy, in the care for ALK-positive patients, and in outcomes. So Tom, wherever you are.
A very moving video, just great. I recognize some of the faces there, but I don't really know what to say, but thank you for putting it together. To give background, I'm a clinical trialist, and so most of my work has been the classic p-value response rate Kaplan-Meier. So when Ken called and asked me to participate in this, I was like, yeah, I'm more than happy to participate. I'm a little bit unfamiliar with the techniques, and so it's been a learning curve for me as we go through this, but I think it really serves a valuable point of view, because the patient perspectives are often hard to capture, and there is a unique science behind this. Just to give you some of the study background, obviously the treatment for ALK-positive lung cancer was changed by the discovery of the rearrangement and development of crizotinib. Subsequently, 3rd-generation ALK TKIs have been developed. They have increasing potency, better CNS penetration, and ability to cover the ALK resistance mutations and mechanisms. Right now, we have multiple first-line therapies that are available, and each has its own set of side effects and benefits. They're listed there in alphabetical order. I think all of you are familiar with these. However, there's a lack of a clear understanding of how patients would prefer, which one of these they would prefer, and also patients are getting more and more engaged in the decision-making. I also think from the physician side, there's a lot of dilemma and a debate about what is the most appropriate therapy for patients, each individual patient and collectively. So with this study attempts to quantify ALK-positive non-small cell cancer patients and oncologists' preference for attributions of systemic treatments and the trade-offs they're willing to make among these attributes when selecting a therapy. Now looking at this, what are patients' preferences? Patient preference information enables behavioral insights. If we look at patient perspectives, there's sort of two broad categories of this. One is the patient-reported outcomes, and this is the classic, what we collect in our clinical trials, quality of life, symptom deterioration, lung cancer symptom scale. I think they're very valuable, but in this situation, all of our trials have compared next generation to crizotinib or chemotherapy, so they don't really reflect the decision we face in clinic every day. Patient preferences, which is the focus of this study, is assessment of the desirability or acceptability of patients for specific alternatives, outcomes, and other attributes. And I think that we're really looking to see is there a difference in preferences on the benefit-risk ratio between drugs and choosing one treatment over the other. The study objectives, one is to sort of quantify the preference of patients with ALK-positive and oncologists for treatment attributes influencing system choices, and to quantify the impact of ALK treatment attributes on patients' physicians' preference by measuring the relative importance of key attributes. And what I think we're really talking about, do patients want to avoid toxicity A, or are they willing to tolerate toxicity A, or toxicity B, and what are the things that really drive the patient decision-making? The second thing is we need to look at different subgroups of patients and physicians. Importantly, patients with brain mets may have a different set of priorities than patients without brain mets and other aspects of this. And so this is the US study population. It starts with a pilot study, which we've completed, which is a 90-minute telephone interview of 20 patients and 10 physicians for a total sample size of 30. The physicians, they had to treat ALK-positive lung cancer, and we wanted a diverse sample in terms of experience, practice, location. For the patients, they had to be ALK-positive and on a systemic therapy. We wanted a balance between first and second line therapy, patients with and without brain mets. And we want the study to represent the US patient population. Many of us are aware that there are significant barriers for participating in clinical trials, and our clinical trials are not representative of the US population. But the hope is this type of study will gain more access for patients to participate, and also get a chance for patients of a wide variety of economic, racial, ethnic things to participate. If you look at that second line, the second phase is a 30-minute online survey, so it's very accessible to patients at this. This is the study phases. The top row, the purple dot, is the part that we've completed. It started with sort of a targeted literature review on ALK-TKIs. We really tried to select the attributes which were most important. This is a study, and it's an IRB study protocol, and we completed the cognitive pilot interviews. The green dots represent what the phase we're in right now. We're updating the protocol, incorporating the feedback we got from the first phase into the next phase, and developing the statistical analysis plan. And then these are sort of the color coding here. The blue represents one of the questions, is convenience. Pill burden's frequently discussed. Is it really a factor in selecting therapies? Looking at the benefits, we kind of looked at the control of the ALK-positive lung cancer, chances of the current regime preventing brain metastasis development, and also preventing tumor progression in the brain. And the risk, we looked at metabolic events, and this was a composite of hyperlipidemia or lab abnormalities that may necessitate medication, weight gain. And one thing we've already discovered is we're going to have to split them because they were too confusing. And then we look at the risk of central nervous system symptoms, fatigue, muscle and bone pain, trying to think of the most common and also the most impactive symptoms that patients experience, and what they said in the cognitive interview. So this is admittedly a busy slide. on the left of mine is, you see the figure there, and what we're trying to look for is different symptom scales, and what you have there is the rate of some of the symptom scales. Then you have on the risk, either the rate, and we've kept these little pictures in there to describe fatigue, because I don't think we want to use the classic CTCAE grade 0, 1, 2, or 3. I don't think that communicates well on the impact of the symptoms at that point. Then you see the treatment burden down there based on the number of pills at this point. And then the other area is the thresholding, and what we're trying to decide, if we can, is what the threshold is. A response rate 40% different than a response rate to 50% in the patient perspective, or what's the magnitude of the difference, and what are the trade-offs they're able to make. And these are very hypothetical scenarios, so they're difficult, but we hope by including enough patients and physicians, we can get an aggregate idea of where the trade-offs are made. And I think this is important not just for the ALK TKIs that are available right now, but maybe the future ALK TKIs, because there's going to be inevitably new agents entering the market and other things, and we have to think in the future. Now, these are high-level results. This is the first 20 patients and 10 oncologists, and this was completed in June. The patient characteristics on the left, the median age was 52, 60% were male, 40% were female. And if you look at the time of diagnosis, 15% less than 2 years, 40% 3 to 5 years, 45% greater than 6 years. And if we kind of look at the oncologist characteristics, we queried how many prescriptions they write in the past 12 months rather than the patients. And you see there that there's a variety of one per month all the way up to greater than 5 per month, as well as the practice setting. Now, these numbers are small, but as we move forward and we get the larger numbers, I think we were hoping to see greater diversity in the patients as well as the oncologists who participate. These are the higher level results right now. I think that what we really found that the most important attribute by oncologists and patients was related to treatment efficacy, particularly lung cancer control, followed by brain metastasis prevention and control. Patients were concerned about treatment-related adverse events leading to dose reduction or treatment discontinuation, and I think that's one of the things that we found when we did this. It's not the absolute grade, but it's what is the impact on my therapy? Am I going to have my therapy compromised because of this side effect or because of this drug interaction or anything like that, such as that? And for the most part, they were willing to tolerate AEs in exchange for efficacy, because I think that the primary goal we found was cancer control. Out of all the tested attributes, we found the least important one to patients was pill burden, and I think this is something that frequently comes up in discussions, but at least the data to date has not really shown that that's a big factor in selecting the therapy from the patient perspective. Now there's patient testimonials, and I'll flip these forward and let you read them. We've kind of highlighted this, some of the aspects of this. And these are taken right from the transcript, so they're not edited by us or anyone at that point. And as you see there, I'll read out one. Controlling the cancer in general is the most important. Second was stopping my brain tumors from getting worse because I already have them. Stopping brain matters from developing. And honestly, my concern is controlling the lung cancer, then the side effects. I'll deal with the side effects. And then here's another one. In the treatment regime, if I take 4 pills a day or if I take 1 pill a day, that doesn't really make a difference. I just want to know how effective the treatment is. And this last one, but definitely something that will let me live longer. And going along with live longer, it has to have good brain penetration, because the brain mass is a common thing for people with ALK. And symptoms, you may want to be able to enjoy things in life, so not having terrible side effects from the medication. Those are the big 3. Now, we're about to move to this next phase, which is represented in the gold dots, where the main data collection and analytics and reporting. And this is where we're really feeling the instrument that we've been developing in terms of the attributes, the scaling, and even the pictures we're looking at to make sure that they communicate correctly. Now, If you're interested in participating in this study, it's open only to the U.S. patients for those of you online. But I think there's a contact number right there. Please be sure to provide your first and last name, phone number, and email address. We really want a broad patient population to make sure it's representative of ALK patients regarding race, ethnicity, educational level, brain mets, disease characteristics, lines of therapy. And then we'll work on continuing to recruit this. And it's a 30-minute commitment, so it's not the 90-minute that the early phase interviews were. And that concludes my slides. I've left some time for questions. I think this is a unique opportunity to really get the perspective of the patient without a filter through the physician. And thank you for inviting me.
Thank you, Tom. I'd just like to make a comment before we open up for questions. And Kirk, I'm not sure how we're doing questions. This is the first time for us. The first 20 patients who Tom just described, the majority of those are probably in this room. And I wanted you to know that when we got that information, we used it. Could we go back? Or I can go back. Yeah. When we got that information, and Tom will vouch it, working with the Pfizer team, we've changed the questionnaire because of your input. And that was the whole purpose, right, yeah, of doing, so you can know that that's been valued and taken care of. Second of all, we want diversity representing the US population, as Tom said. So we want people from African American, from the Asian community, from the Hispanic community, and a reflection of the diversity of the country we live in. So that's really important. So if not only take this information down and apply, but please pass it along to everyone you know, because we really want to get those 150 slots filled up. The sooner we have this information, the sooner we can communicate it. So, are there questions for Tom? Looks like Kirk's ready to.
Yeah, we got a mic over here. If you got questions, raise your hand.
Okay.
Yep.
I'm going to sit down.
Who is the question? It's coming.
It's just a simple question. I wasn't able to read the phone number up there from here or the email.
Maybe we can share this.
Kirk, what's the best way for us to get this slide to everybody?
Yeah, I think sharing the slides is going to be the easiest way, so that you don't have to write it down on a scrap of paper or something like that. And we're more than happy to share the slides.
Oh, okay.
Well, we can give you the phone number now, because that's easy.
978, Ken's eyes are pretty. 801.
I can't, wait, can't hear you.
Sorry for our technical difficulties. So the phone number is 978-801-9114. The email, we'll probably have to give you the slides so that you get the email correct. But that would be the contact person.
That's great. Thank you.
I got this one on.
Okay, I have a question. Is the goal of the study to be able to tell the makers of the drugs what to prioritize in the actual making of the medication? Is that what we're hoping the outcome will be of the usage of the information?
I think the primary goal is to let physicians and patients know what they think is important. You know, particularly I think there's a lot of physician perceptions of what they think is the patient is important, but this would do that. You know, down the road, maybe this information will be used in drug development and saying, like, you know, we know from previous studies that this level of side effects unacceptable to or acceptable to a patient. But the primary goal is really to inform physicians and patients.
Was there a question over here, Nancy? Okay.
I see another question, right? The lights are.
So my prediction is that if you stratify it by age, you're going to find quite a difference between what someone that's 30 years old or 40 years old with children is going to prioritize versus someone that's 70 and financially secure and their kids are all growing up. Is that going to be somehow incorporated into conveying the findings of whatever you find in your studies?
Yes, yes, we're collecting age, and we're going to look at all the demographic and clinical variables and trying to see there. I think you bring up a very good point that there's a lot of personal factors that lead to treatment selection that maybe are not captured in the classical clinical trial.
So I guess my kind of a follow-up to that is just, rather than aggregating the results, would they sort of stratify them and share that stratification of the results?
I anticipate us presenting subset analyses and other aspects.
There's a question back there.
Just a follow-up question to that. A lot of these studies, and even some of the slides that I've seen, you know, they list a median age of 50. I was diagnosed at 33, so I am clearly way below that. But I find that a lot of things that are not really talked about as much in these studies are fertility issues, especially for young women who tend to be diagnosed. So is there any outlook on that? Is there going to be any clinical trials or anything to that degree that can kind of let us know, since we're living longer on these medications, how does that impact fertility?
It's a good question. We have not incorporated that. I mean, we'll have to think about that.
So can we, Jessica, is the young lung cancer study going to be looking at those kinds of questions?
Not specifically at fertility, but the young lung studies baseline and It's called cameo appearance, right? No, not specifically at the fertility question with the young lung study. So the young lung study is really meant to be looking at germline and hereditary genetic factors that may be linked to lung cancer development at a young age. And I'll just take this opportunity to emphasize that when we use the age threshold of 45, that is not meant to be your age right now. That is meant to be the age at which you were diagnosed with lung cancer. So even if you're 50 right now, if you were diagnosed with lung cancer at age 44, then you'd be eligible for the study.
We do have one question for the virtual. And as far as the study, do you have to have brain mets in order to participate?
No. No. No, we want a mixture of patients with and without brain mets.
Can you hear me? Yeah, okay. So since ALK is like 3% or 5%, whatever, of the lung cancers, but since it tends to hit people younger. So if you go to younger ages, is it a much larger percentage of people that are, say, 20 if they had cancer, more percentage than 3 to 5% would be ALK?
Good question. And I think if you look at the people under the age of, we'll say 45, the majority of them have an oncogenic driver, and the prevalence of ALK is higher at that point.
Yeah, and we want more of them, all those people in our community, right?
Is it on now? Okay, there we go. Obviously, ALK patients are often on these drugs for many, many years. And when I was looking at the data, and I might have missed something, but assuming a lot of the TKIs are comparable, right, in controlling, your first wish is always control the cancer, right? No matter, almost, we're willing to forego a lot of costs at that. But let's presume more or less the PFS, the OS is the same for the TKIs. And I think then you start asking patients, what do you think about the side effects? I think those are also important questions, right? How much is fatigue an issue for you? Again, if you're a young person, can you continue to work? The questions about family, right? When you're hit much younger and you're in the middle of building a family, you know, your high earning income years, all of those things start to really weigh in on you, and maybe your view of side effects is quite different.
Agree.
You're good.
Thanks, Yvonne. And that's a centerpiece of this. A centerpiece of this is trying to dissect down to the different kinds of side effects, if that's relating to your comment. Somebody's raising their hand back there.
Hi, sorry. Yeah, thank you for coming and doing the study. I'm curious to what extent you see a mismatch between physician preferences and patient preferences, and to what extent there's sort of a paternalism with physician preferences not necessarily taking into account patient preferences. And let me give you an example. I think you know, there's sort of a clinical debate right now about whether alectinib or lorlatinib as first-line therapy, you know, which one. There's a debate at TTLC this year, sort of on the clinical side. And there's also differences in what patients would prefer, whether or not they're willing to tolerate, you know, the side effects, trading off the side effects for potentially longer PFS and OS. But it does seem like currently alectinib is sort of the default for most practices, whether that's in community, even among academic oncologists. And often, I think these decisions are made without sort of consulting patients. And so I think, you know, some oncologists are sort of offering the choice these days between the two and laying out the pros and cons. But it seems like this is not widespread yet. And so I'm curious as to your thoughts on whether this is a sort of a clinical question, whether oncologists aren't sure, you know, which one is more efficacious medically, but also whether or not they're taking into account those patient preferences. I don't know if that makes sense, another question.
Complicated question there. I will say that when Ken and I looked at the preliminary data, that there are some discrepancies in the priority from the physician and the patients. Again, 10 versus 20, but weight gain seems to be a much more higher rate concern for patients in terms of the side effect profile and fatigue. And so I think that now that it's too small for us to flesh this out right now, but that's really the purpose of the larger study, to see are there things that physicians are not telling patients that the patients are actually concerned about, and do we need to have a better discussion about some of the chronic toxicities? As someone who treats lung cancer, I would hope that everyone gets presented all their options up front. You know, I mean, I don't think anyone, especially when there's, you know, debate and parity in the field. And so, you know, I mean, I encourage and hope that all physicians discuss all the ALK TKIs listed there and their strengths and weaknesses, so that the patient may choose, you know, young patients may choose lorlatinib, maybe patients with a higher CNS burden will choose lorlatinib, and it should be the patient's choice.
Is this on? Yeah. When we were diagnosed 4 years ago, we were given no choice, period. This was at Yale. They said, you're going to go on alectinib, and that was that. and we didn't know any better. Has that changed now where patients are presented with various alternatives and alectinib is not the automatic default?
I think in my practice and among the academic physicians here, I think most of us present all the options. And I think, it's hard to say 4 years ago, but I think most of us are intrigued by lorlatinib, the long-term follow-up, the CROWN data. Brigatinib remains an option. I don't offer crizotinib because I consider it an inferior product. And I think because it's been inferior in phase 3 trials, I don't think it's appropriate to offer that. Personally, ceritinib has a little bit harder tolerability issue, so I generally do not present that. I mentioned it, but I say that I don't consider this really a viable option, and that's how I approach the patients.
We do have a remote question, and is the study confined to those under 45?
No, there's no age restriction on the study. The young person's study, which I encourage everyone to participate in who's on the thing, is restricted to the age of diagnosis at age 45. And they're two separate studies.
Steve. There we go. So is this intended to be preferences for a first-line treatment only, or for any treatment?
First and second line and third line patients can enroll in this study. There's no restriction on the number of lines.
And I guess kind of the second part of the question is...
Go ahead.
And I guess the second part of the question is, I saw the options of treatments that you had there. Is there an attribute in additional lines of treatment beyond that might be something interested to look at, or potential next steps, or the availability of next oral steps that might be an important piece as well?
That's an important piece. I think what we really were focusing on sort of the benefits and the risk associated with the therapies that are available to us. I think it's a valid point. I'm not sure how we would really structure a sequencing question into this. It'd be very, very difficult.
I would like to just say, for patients who've been on multiple TKIs and have had experienced side effects on the different drugs, this may be more valuable than someone who's only been on for a short time on one. So, but as the question was brought up about, 20s and 30s, maybe the right question for them is the first one more than the later? So we're capturing all that, and to the extent we have the statistical power we'll have 170, I think, in the end, patients, then hopefully we can start to look at those different groups. And hopefully Pfizer will decide to fund something after this where we can dig into some of the issues that this raises. They've been very generous in sponsoring this trial. So I just wanted to say thank you to Pfizer for giving us the community opportunity to learn and be able to share what you care about with the drug development world and your doctors.
And I think that's a good point. That I think this is the first step, because as far as I know, a study like this has not really been done, and hopefully will. Every good study leads to more studies, and so I think this is sort of the first step. And many people brought up many points and flaws in the study, but I think we need to start somewhere and maybe refine on the next study.
Hi, I have a question. If you have a patient who is just having a lot of non-dangerous side effects on alectinib, which from our Facebook group, I gather a lot of people do, the tiredness, muscle, weight gain, would you consider just offering them brigatinib? And if not, why not?
This is a difficult question. I think I would really sort of talk to the patient about what the side effects, how their daily life is doing, what dose of alectinib they're on, what's their CNS disease status. I think we're a little bit hesitant to reduce alectinib if there's CNS disease because we don't want to lose control of the brain. And then I'd look to some of our palliative care and supportive care people. Can they mitigate some of these symptoms to make it more tolerable? I think everyone, inevitably, some people do have to change ALK TKIs, when we just cannot mitigate the side effects at some point. And I think that's one of the harder decisions we make. Because if two risk, I think if the disease is controlled, you're always hesitant to change therapies at that time. And two, the alternative therapies may have other side effects or may not be better tolerated. And so there's no guarantee that the next ALK TKI would be better tolerated than the previous ALK TKI. And that's one of the things we worry about.
Thanks, Dan. Thanks, Tom. You.